Okay, so we are doing an interview on today, April 15th, 2013, with Dr. Marvin Baum. How do you do?
I'm fine, thanks. How are you?
I'm great, and we're here and we're very interested to hear about your life and your career. Where did you grow up?
I was born and raised in Paterson, New Jersey.
Oh, and during what era were you raised?
I was born in 1921.
Oh, so you lived through the Great Depression and World War II?
That's correct. My father and mother struggled financially through the Great Depression, and I served in the Navy during World War II.
Wow. And did you get much education before you went off to the service?
I finished college before going off to service.
Where did you go to college?
University of Alabama.
And what did you major in?
Chemistry.
Did you know you wanted to be a doctor then?
I knew I wanted to be a doctor when I was about 7 years old.
Oh yeah, what made you make that decision?
I have no idea. I can only remember wanting to be a doctor that far back.
Were there other doctors in your family?
No, my family was a working class immigrant family. I was the first member of the family to go to college.
Oh, that's great. And you went to college during the Depression.
I went to college from 1939 to 1943.
Wow, excellent. And then you came back from the service, and you went to medical school right from then?
No, I went to medical school while I was in the service.
Oh, and where did you go to medical school?
New York Medical College.
Great. And so you would have graduated
45.
1945. Excellent. And then you did a residency?
I did my first year rotating internship in the Navy. And then came to Worcester because I had married a Worcester girl and had my residencies at Worcester hospitals.
Excellent. And you specialized in?
Internal medicine.
And did you do any subspecialty work during your career?
I spent some of my residency time at a hospital which is no longer in existence, a municipal hospital which is no longer in existence, called Belmont Hospital. Belmont Hospital had an infectious disease division for diseases which no longer require hospitalization because we now have antibiotics.
Right.
They also had a tuberculosis division, which is no longer in existence either, because even tuberculosis no longer needs hospitalization. In those days, a person with tuberculosis had no treatment except for bed rest and a high-calorie diet, and hospitalization lasted an average of a year or two.
Right. So Belmont Hospital was in Worcester?
Do you know do you know where the new vocational technical high school is?
I do.
That's where it was located.
Okay. Wow. And tell me about your residency. What was life like then?
Well, I had my residencies at City Hospital, Belmont Hospital, and St. Vincent Hospital. Except for the residency for the brief residency at City Hospital, which was well organized, the other residencies were ones in which I was the only resident or one of two residents, so I didn't get much time off. I worked a minimum of every other night, every other weekend, and it was hard, but I enjoyed it. One of the advantages I've had is that no matter how hard things have been in terms of work or lack of sleep, I always enjoyed my medical education, my medical practice so much that it never seemed a hardship to me.
That's great. And were you married during your residency?
Got married while I was still in medical school. I could afford to because I was in the Navy and they were paying me $100 a month.
Excellent. And where did you live when you were a resident?
Most of the time with my in-laws. When I was at Belmont Hospital, the hospital provided an apartment for us, for me and my wife and our baby.
Excellent. And did your wife have a job outside the home when you were a resident?
No, she was busy. She was busy raising a child.
Uh-huh. So basically, you were living off your resident salary.
I got a lot of help from my in-laws,
Okay.
to whom I will always remain grateful.
Ah, that's great. And do you have an idea of what pay was? Do you recall what pay was when you were a resident?
The pay was $100 a month,
Okay.
plus room, board, and laundry.
All right. And you were on every other night. Now, on the days that you weren't on call, how long would you be at the hospital?
All day? No, I shouldn't say that. It's so long ago that I don't really remember clearly.
Mm-hmm.
No, I think that on the days after a night on call, I was free when I finished morning patient rounds.
Mm-hmm.
And usually that was about noontime. I'm pretty sure that's correct.
Did you have much time to spend with your wife and children during your residency when you were awake?
Every other day, yes.
Mm-hmm. Okay, great. And what sorts of diseases did you treat when you were a resident?
Well, at Belmont Hospital, I treated scarlet fever and measles encephalitis. Of course, in the TB division, we treated pulmonary tuberculosis. At City Hospital and St. Vincent Hospital, where I spent some time, I treated the usual run of internal medicine disorders.
Mm-hmm. So in the 1940s, what was the usual run of internal medicine disorders?
Coronary heart disease, pneumonia, upper GI bleeding, stuff like that.
And you were beginning your practice just at the dawn of the antibiotic era.
That's true. Actually, I was in the service before, I was in the Navy before penicillin was the first antibiotic available. I was in the Navy before antibiotics were available to the civilian population. So in the Navy, I gained experience using penicillin.
Mm-hmm.
At a time when there was a committee, I should say that when I got into civilian hospitals after my Navy experience, in every hospital there was a committee because penicillin was in such short supply, to decide which patients deserved to get penicillin and what the dose should be.
Mm-hmm.
And the doses, I want to tell you, in those days were minuscule compared with what's being used now.
Right. It was, what, like 100,000 units or so?
Much less than that.
Even less than that?
Yes.
Okay, great. Yeah, we use millions of units now, and so that is quite a difference. And how else did you treat infection besides using antibiotics?
During my training, penicillin was the only drug available for treating. It was the only antibiotic available for treating infections.
Did you find that more infections ended up requiring surgery than perhaps is the case today?
I would say that's probably true. I remember, for example, at Belmont Hospital, seeing a case of a strep throat that developed into a pharyngeal abscess before penicillin was available and required incision and drainage.
Mm-hmm. Mm-hmm. Wow. And when you were treating heart failure, how was heart failure treated in those days?
Well, we had digitalis leaf. This was in the days before digoxin and digitoxin. And we had mercurial diuretics, which were given by injection. The oral diuretics like Lasix, That was a late, a very late comer. Or hydrochlorothiazide was the first one,
Uh-huh,
but that wasn't available either when I was in training.
uh-huh, uh-huh. And was it common to see people dying of heart failure or heart attacks on their first attack?
I guess more common than it is today. Of course, we didn't have cardiac care units in those days,
Mm-hmm.
or, or intensive care units. So the care was not as precise as it is now, and the drugs were not many drugs were not available.
So what kind of nursing care would be delivered to someone who was in heart failure?
I can't remember the details.
Okay, all right. And so as time has passed, when, if we look at heart disease, what strikes you as having changed over your career?
Well, I still read the New England Journal of Medicine. I don't understand most of it now, but I understand enough of it to know that the treatment of most diseases, and especially of heart disease, has improved tremendously since I started my medical practice.
Mm-hmm.
But the details of how those changes have occurred, I really can't say.
Mm-hmm. And so you finished your residency in the late 1940s?
Finished my residency, well, before we go into that, I'll make a confession.
Mm-hmm.
The reason I had part of my residency at the tuberculosis division of Belmont Hospital is that I came down with pulmonary tuberculosis
Oh, boy.
during my residency, and I spent close to a year as a patient there.
Wow.
And when I recovered, I stayed there as a resident for about a year and a half before I went on to my internal medicine residency at St. Vincent Hospital.
Mm-hmm. Now, were there anti-tuberculosis drugs available then?
Yes and no. When I was first admitted in 1948 to Belmont Hospital TB division, there were no drugs available. A couple of months after I was admitted, a paper was published about the use of streptomycin, which was the first drug developed after penicillin, about streptomycin being effective against tuberculosis. And so beginning 2 or 3 months after I was admitted to the hospital, I received, I think, a gram or half a gram a day intramuscularly of streptomycin for 6 weeks. And that was the extent of my chemotherapy for tuberculosis, or antibiotic therapy for tuberculosis. And I want to tell you, after the 6 weeks was over, I had one sore behind.
Okay. And during that era, what other treatments were administered for tuberculosis?
A barbaric treatment called artificial pneumothorax, which I underwent. The right-sided pneumothorax for 3 years, 3.5 years. There were surgical treatments. We had a thoracic surgeon on staff who would do lobectomies for diseased lobes with cavities that were too big to heal by themselves. There were, I don't remember the name of the operation, but he also did an operation in which he would remove several ribs from the upper thoracic cavity, so that the unsupported thoracic cavity would collapse on the lung, collapsing the lung on the cavity, and frequently that resulted in arresting the tuberculosis.
Wow. And in those days, tuberculosis was one of the top killers in the nation, as I recall.
And it still is in other countries. Fortunately, we have it pretty much under control in the United States, except for immigrants, I understand. Immigrants from places where the disease incidence is high.
And, excuse me, what other diseases did you treat besides heart disease? Did you treat hypertension early in your practice?
A lot of hypertension, yes. There wasn't much treatment for hypertension at that time. The first treatment for hypertension that I became acquainted with was phenobarbital, which, as you know, is
Tranquilizer.
well, we didn't use the word tranquilizer in those days.
Right. Got rid of the tension.
The fact of the matter is, in those days, the theory was that arterial hypertension was due to nervous tension.
Sure.
And it was thought that phenobarbital, by relieving the nervous tension, would help the high blood pressure. But we subsequently learned that that wasn't really true, and
Right.
subsequently more and more effective treatments became available. But that's all we had at the beginning,
Sure.
phenobarbital.
Yeah, I had asthma in the 1950s, 1960s, and they thought that was a nervous tension disease as well. So phenobarbital was a component of the drug that was used to treat me as a child.
Well, one of the bits of wisdom that one acquires as one practices medicine and goes through life is that not everything is due to not everything is psychosomatic.
Yeah.
There were so many diseases when I began practicing medicine that we thought were psychosomatic, for which etiologies have been found.
Right.
And most of the etiologies that have been found for these so-called psychosomatic disorders are autoimmune now. Autoimmune.
Yeah.
There was no concept of autoimmunity at the beginning of my medical practice.
How common was pulmonary disease in your practice?
Well, I think my experience was probably not typical in that, because people that I had met at Belmont Hospital during my own hospitalization started coming to me for their medical care. So I saw lots of people with tuberculosis and other pulmonary disorders. Probably my practice was weighted in that direction.
And what about smoking in those days? How common was smoking?
Well, in those days, if you didn't smoke, you were not sophisticated. You can probably tell that from watching movies of the 1930s and 1940s. It was a cool thing to do, and it was only in the late 40s, early 1950s that a pathologist at the VA hospital in West Orange, New Jersey, published a paper on a series of autopsies he had done. And he managed to figure out, as a result of these autopsies, that the autopsies in which he found pulmonary lung cancer were in people who had been smokers, cigarette smokers. And he also described histologic changes in smokers who did not have cancer that he considered to be precancerous lesions. That was the beginning of it, but that was not until the early to mid 1950s.
So when did you go into practice?
I started practice in 1952.
And where did you begin your practice?
I made the mistake of renting a downtown office. It was a mistake because I was not unknown in Worcester. My office was tucked away in a place where nobody could find me. I guess I was not a very good businessman. So I survived there for 3 years, and then my in-laws gave me the home in which they had lived for 30 years and suggested that I build an office next to the house, connected to the house. So I borrowed some money from the bank, built an addition to the house, opened an office there, and within a few weeks I had more work than I knew what to do with.
Location, location, location.
That's right.
Interesting. And so where was this office located?
Corner of May and June Streets in Worcester,
Oh, okay. Great.
not far from Fairlawn Hospital.
And which hospitals did you go to when you were in practice?
Well, I had my residency at St. Vincent Hospital, so of course I got an appointment there. And I got an appointment at Fairlawn Hospital. And then when the medical school started, I was one of the first
Faculty.
one of the first teachers there before there was a full-time faculty. So because of that, they gave me admitting privileges at the university hospital. But I didn't use that very much.
And did you cover with other doctors? Did you associate yourself with other doctors when you began in practice?
That was a difficult problem for me. You probably know that I joined the Fallon Clinic after 19 or 20 years in solo practice.
Right.
And a major reason why I did that was that I was never able to get adequate coverage for my patients when I wanted to take time off. So not only did my patients not have adequate coverage, but I got to take relatively little time off, and I really couldn't sustain that any longer.
Sure. And in those days and early in your practice, did anyone have insurance?
Blue Cross Blue Shield was founded in the mid 1930s. So many patients had Blue Cross Blue Shield, but that was the only insurance available at that time.
Would it cover office visits?
No, it covered only hospitalizations, then to a very limited extent.
Right. And roughly how much early in your practice, roughly what was the charge for an office visit?
I charged $4 for an office visit, $5 for a house call. And for several years into my practice, most of my work was done at people's homes, not in my office. As a matter of fact, even after I became busy in my office, during very busy influenza seasons, there were days when I made 16, 18, 20 house calls a day, in addition to my office hours.
And roughly how many patients would you see in your office?
About roughly 20 a day.
Okay.
Or sometimes as many as 30.
And when would you get home at night from the office?
Well, of course, my office was right
Your
next
home.
to my home, so it wasn't a problem. I got home for meals, for all of my meals, but I spent most evenings not sitting and chatting with my wife.
And how would patients reach you at night if they needed you?
I beg your pardon?
How would patients reach you at night if they needed you?
They had my own phone number.
Okay, so there were no beepers in those days, as
No.
I recall. And so what would happen if you would go out to the theater or anything like that? Would that be a little tougher?
I'd call into the answering service periodically.
Okay. And what sorts of
Two younger sisters, both of them went to college as well. In spite of the fact that my father objected very strenuously that they'd only get married and have children and their education would be wasted. They were very strong and persistent women, young women, however. Both of them became professionals.
Oh, that's great. So a strong background in the value of education in your family. Your parents undoubtedly conferred that to you. So we were thinking that it may be interesting for you to give us some perspective about your time as a patient and how that affected your practice later in life, because you spent a good long time in the hospital and as a patient.
That's a hard question to answer. It may be, well, I'll try to answer it this way. When I joined the Fallon Clinic, I became a member of a 4-person coverage group. And so that I worked only, I covered the practice only every 4th weekend. And I could take off every 4th night as well as I wanted to. I never did. When my colleagues at the Fallon Clinic covered for me, they complained bitterly how demanding my patients were. So what I'm suggesting is that because of my own experience as a patient, I cater to my patients in a way that most doctors apparently did not. So I got a lot of teasing about that.
So when did you join the Fallon Clinic?
Let's see, I had been in practice for 19 or 20 years. So I began practice in 1952, so it would have been 1971.
Okay. And how many doctors were there at that time?
I was the 16th doctor on the medical staff.
Wow. Okay. And at this time, the Fallon Clinic is called the Reliant Medical Group, and they've got, I believe, 250 doctors.
Something like that, yes.
Yes. Wow, that's wonderful to get in that early. And so you found that that mode of practice with doctors in a number of different specialties was a better way for you to practice at that time?
Well, it was not only a better way for me to practice because of the multi-specialty aspect of the group. It was a better way for me to practice because I no longer had to be concerned about the business aspects of my practice, which I was never very good at anyway. You know, hiring and firing office personnel, collecting money, all that stuff was no longer an issue for me. That was a big I made a big improvement in my life. And then, of course, as I've already alluded to, I got regular time off. You knew that my patients were adequately cared for during the time that I was not on call.
Good. And how would you say the practice of medicine, what are the big changes that jump out in your mind regarding the practice of medicine during your career?
I have a son who's an internist in Plymouth, and when we visit together, I hear mostly the complaints that he has about. I don't have any personal knowledge of what medical practice is like now. Well, I shouldn't say that. I do, because I'm a patient. I've been hospitalized 2 or 3 times in the past few years. My primary care physician has not been able to take care of me in the hospital. I've been cared for by a hospitalist, which I resent very much. A hospital who doesn't know me and sometimes acts as if he doesn't care to know me. Now you're getting me angry.
So during the years that you practiced, what changes occurred with regard to the organization of practice and the role that, for example, insurance paid in your day-to-day practice?
Insurance played little or no role in my day-to-day practice except for patients in the hospital.
Okay.
What was the beginning of that question?
Well, just the way you practice medicine, the number of patients you could see, those sorts of things.
I'd be at the hospital, usually 2 hospitals, beginning at 7 o'clock in the morning, and I'd begin my office hours anywhere from 10 a.m. to noon, and would go till 6 or 7 p.m.
Okay.
I'd see, and during that time, I might make 2 or 3 house calls in addition to making hospital rounds. I might see, as I've already said, 20 or more patients in the office during the day, and maybe a couple more house calls in the evening after dinner.
And how, with regard to the diseases you treated, what sticks out in your mind as advances that occurred during your career?
I'm sorry, my mind is a blank.
That's okay. How about infectious disease? Did that get easier to treat?
It got very much easier. For the infectious diseases that are susceptible to antibiotic treatment, there are diseases which are not susceptible to antibiotic treatment, like measles and chickenpox, which some people consider to be minor childhood ailments, but they're not. But with modern vaccines, even those are not the horrors that they once were.
And
I'm not sure, since your specialty is not medicine or infectious disease, you may not know that both measles especially, but both measles and chickenpox can cause horrible complications like encephalitis, and myocarditis and pneumonia. And pneumonia that's really very difficult to treat. And those are things that I saw at Belmont Hospital.
Wow. And now you specialized in adults, so you did not take care of children?
When I first began my practice, I saw older children as well as adults.
Okay.
Because at Belmont Hospital in the infectious disease division, most of my patients had been children. So I felt as if I had some, I felt I was qualified to do this. But as my practice got busier and busier, I couldn't handle everything, so I eliminated children from my practice after a few years. So only adults.
Okay. And did you treat, besides pulmonary diseases that were infections, did you treat chronic obstructive pulmonary disease? Did you treat asthma during your career?
Yes, I did.
How did that change? How did the treatment of those conditions change?
Well, the only treatment that was available for years after I began practice was aminophylline, by mouth or intravenously. And then after a while, the inhalants became available, which were much more effective. So I got to use those, but not for as long as I used the less effective stuff.
And with regard to GI disease, did you see much in the way of gastrointestinal disease at all?
Most of the serious GI disease that I saw had to do with peptic ulcer disease and bleeding from peptic ulcer disease. And now, when I first retired, this was starting to disappear, and I understand that it's almost completely disappeared.
Right. That's another one that was thought to be related to nerves and being too tense.
Yeah, for example, one of the most common operations when I was in practice was a subtotal gastrectomy for intractable peptic ulcer disease. There's hardly any gastrectomies done any longer except for cancer.
Right. And I mean, today it's appreciated that infectious disease plays a role in these ulcers. And so that does make it less common. And did you treat any skin conditions, or did you do any dermatology at all?
Don't remember.
Yeah, that's a tough one. I don't, that's, you either do those or you don't, and I don't either. And with regard to routine history and physicals, an annual exam or anything, was that something that was commonly done back in the 1950s and 1960s?
It was something we promoted. We thought that it had a great deal of value. Yes, so my adult patients, I would encourage them to come in once a year, even if they didn't see me for anything else, for complete physical examination, CBC and urinalysis, electric, and if age appropriate, electrocardiogram and chest X-ray.
And you would do, so it was common, particularly in those days in which TB was as common as it was, to do a chest X-ray every year on patients.
Yes.
And probably had a fair yield as well.
Not as great a yield as it should have been for the effort involved.
Okay. All right.
Or for the expense involved.
All right. And what other changes did you notice at the Fallon Clinic over your period of practicing there?
Well, I can't say that I noticed any change in medical practice. The change was in the culture of the clinic. And the reason for that was simply that it got so big. When I joined, and for a long time afterwards, the Fallon Clinic was like a family. Everybody, we were all friends. We were all good friends. We went out to dinner together, we partied together, we practiced medicine together. But after a while, the organization got so big that that was no longer possible.
Now, during the 1970s, there was the movement to promote health maintenance organizations,
Yes,
and Fallon was very early to the party on that one, starting the
Yes.
Fallon Community Health Plan. Do you recall any of the discussions that might have occurred as that was evolving?
yes, when I joined the clinic, I think I said in 1971, they were already in the process of developing the Fallon Community Health Plan. And with the assistance, by the way, of Blue Cross Blue Shield. And so I became involved in that before the Fallon Community Health Plan was actually born in a rather minor way.
And it sounds like, although that affected how medicine was paid for, so it affected employers, it affected patients, it sounds like your practice really continued as it usually was. It wasn't something that had a significant effect on your practice.
That's pretty much it. The only major change I found in my medical practice was that although after I joined the clinic, I was still willing to make house calls. Almost from the first day I joined the clinic, people stopped calling me to ask for house calls. I guess they assumed that I was now a member of a big impersonal organization, and house calls were no longer to be expected.
Interesting. And the other thing is you're right. Other people weren't doing house calls because they for whatever reason fell out of fashion. Did you find over the years that your ability to do testing expanded in the office? That there were things you could do in the office later in your career that you couldn't do before?
Yes, the Fallon Clinic had a professional X-ray department and a big professional laboratory. But what I should say, though, is that I firmly believe, as a result of my early experience in practice, that visiting patients in their homes is very valuable not only for the patient but for the doctor. It gives the doctor an understanding of the patient and the patient's family that's really very important in dealing with the patient's problems, because a primary care doctor doesn't deal just with medical problems, deal with social problems and psychological problems as well, maybe even more so than the medical problems. And seeing the patient in his own home, surrounded by his own family, gives the doctor really a very important insight into that patient that he doesn't get in the office, he or she doesn't get in the office.
Excellent. And with regard to psychological conditions, how did depression or anxiety play a big role in your day-to-day practice?
I think so. Yes, I think so. As a matter of fact, I'll make another confession. Early in my career, early in my practice, my father died and I became very depressed. As a result of that, I went through 3 years of psychoanalysis. And that experience gave me, it didn't cure me of my personality quirks, but it did give me a lot of insight into other people's personality quirks. I think that was more important to me in dealing with my patients than any of my medical training was.
Yeah.
To me, in retrospect, it's unbelievable how important the social and psychological aspects of the doctor-patient relationship is. So I think that's one of the reasons I cater to my patients, because I guess having had that experience myself, my empathy level was
Right.
was raised.
Exactly. And did you find that medications were effective or became more effective for those conditions during your practice?
Well, early in my practice, of course, there were no, and
Right.
there were no tranquilizers or antidepressants. And I don't really remember how we dealt with those, except by offering sympathy or empathy.
Okay. What other things do you feel are important to sort of pass on to as part of this interview?
What do I think is important to pass on to a younger generation of
Yes.
physicians, you mean?
Yes.
Well, it's hard for me to know what to say without sounding maudlin.
That's okay.
I don't want to sound maudlin.
Uh-huh.
I think, well, let me put it this way. I think that practicing medicine is one of the greatest privileges that anyone could have. It certainly was the greatest privilege I could have had. And when I retired very reluctantly because I got such satisfaction out of my career. And the reason I retired, would you believe that I have a memory problem? I can't remember what to prescribe for high blood pressure. At the end of my practice, I had to look up in the PDR what I wanted to prescribe for these people. And I thought this is getting dangerous. The strange thing is that I've been retired now for over 20 years. And my memory hasn't gotten any worse as far as I can tell. But I still think I did the right thing in order to avoid hurting anybody. But if it hadn't been for that, I think I might still be practicing, and I'm 92 years old.
Oh my gosh. And are there any other advances in medicine that have left you pretty impressed?
Would you repeat that, please?
Are there any advances in medicine that have really impressed you in the past several years, let's say?
There are so many that I wouldn't be able to begin to enumerate them. As I told you earlier, I read the New England Journal of Medicine every week, or I try to read it, and there's relatively little of it that I understand now because scientific advances, clinical advances have been so unbelievable that it's gotten way past me.
And conditions that are treated today are perhaps a little different than conditions that were treated at the beginning of your career. There's been sort of a drift in what has affected the population. Was cancer a big problem earlier in your career?
Yes, it was.
And what sort of cancers did people have?
Lung cancer was always there. Stomach cancer was always there. I can't remember others.
So, in those days, from a point of view of screening tests, early in your career, would women have pap smears done?
I don't remember when pap smears began. I would say that at the very beginning of my medical practice, no, there were no pap smears.
Right.
But it wasn't very far into my medical practice when we started doing them. And when I would see a woman for a routine annual physical examination, that would be one of the things, of course, that I would do.
And mammograms, those probably came into practice a little later in your career.
That's correct.
Probably 1970s, 1980s or so.
Probably, but
Yeah.
I don't remember for sure.
Yeah. And what other screening tests do you think are particularly valuable? Would you screen cholesterols back in the 1950s and 60s?
We had no knowledge that cholesterol
Right.
was an issue as far as health is concerned.
Right.
That also developed much later.
And as far as advice regarding obesity, was obesity a big problem in your early career?
I don't remember there was a big problem, but it was certainly a problem. And it was always very difficult to deal with. I'm sure it still is very difficult to deal with.
Yes. Okay. And HIV or AIDS was essentially came into being late in your career.
It was during less than the last decade of my medical practice that HIV/AIDS started to be talked about.
Right.
So I don't think I ever saw a case.
Right. That was in the 1980s. And so you retired in 1988, and then you returned to practice shortly after and practiced for another.
But another 7 or 8 years, but it was
Yeah.
not treating disease.
Yeah,
It was mostly doing pre-employment physical examinations.
okay. All right. Good. And okay, well, what other thing, is there any other thing that you'd want to highlight with regard to medical education, with regard to the current changes that are occurring in our healthcare system that you might have some observations on, some perspective?
No, I don't think so.
Okay, all right, very good. Okay, well, this has been, I think, a fascinating interview for me. I enjoyed listening to you and hearing about your career.
It's been fascinating for me too.
Yeah.
It brings back memories that I didn't know I had.
Uh-huh. Well, I find just the practice of medicine, through the 40s and 50s and 60s, it was just such a dynamic time in medicine, and so many discoveries were made, and I think that from the perspective of today, we don't appreciate how significant some conditions are that today are much more easily treatable. Infectious disease in those days much more often killed young people than they do today. And so the advent of antibiotics has made such an enormous difference. And the advent of medications for coronary artery disease has made a huge difference over the years as well. It was a much bigger problem in previous generations. So, yeah, you lived through a really interesting age in medicine, and you practiced through an interesting age where so many discoveries were made, and your ability to make a difference greatly advanced during your career. That's wonderful. Okay, well, thank you very much.
Interesting part of advances in medicine. I was in the Navy Hospital at Portsmouth, New Hampshire, which is no longer in existence. He was about a 32-year-old sailor who had had an appendectomy. I was not involved with the surgery, but I was involved with his post-operative care. And in those days, after any abdominal surgery, including a simple appendectomy, patients were kept in bed for a minimum of 10 days. Couldn't put your foot on the floor for 10 days. He was in a long ward, one of those old-fashioned wards where there's 2 or 3 dozen beds lined up. In the day, he was first allowed out of bed. He said, "This is wonderful. Now I can go to the bathroom instead of using the urinal." He hopped out of bed, started walking to the head, and dropped dead on the floor. And the autopsy showed pulmonary embolus.
Wow.
How did that affect you?
It horrified me.
Yeah. How did it inform your practice going forward?
Well, not very much, because I guess my reaction to it was, well, the guys who keep him in bed 10 days know a lot more than I do. I was just out of medical school.
Yeah.
I guess that was my attitude.
And yet bed rest was sort of a big part of medical care.
It was not only part of medical care, it was part of obstetrical care.
Right.
In those days, a woman stayed in bed for 10 days, a week or 10 days too, after delivery.
After childbirth, right.
Now
And
she gets up and goes home.
And after a heart attack, how long was someone at bed rest?
At least 3 or 4 weeks.
Yeah. Yeah.
And sometimes I treated them at home instead of sometimes I would say, "Oh, this is another interesting memory." I remember a specific case. I would say, "You've had a coronary thrombosis, I would carry, by the way, I would carry a portable electrocardiograph machine with me and do electrocardiograms at home. You've had an MI or a coronary thrombosis, and there were no coronary care units at that time, of course. And I think that it's not safe for you to take the ambulance right to the hospital. I'm going to treat you at home. And I'd visit the patient every day or twice a day at home. Sounds crazy now.
Now, CPR, cardiopulmonary resuscitation, early in your practice, that wasn't something that was performed. That was something that came in.
Much later that developed.
That was
yes.
developed, right? Yes. Okay. So basically, it was bed rest and possibly oxygen or something like that if someone had a heart attack.
Yes.
Okay. Wow, that's great. Excellent.
What did you learn from your patients?
A little louder, please.
What did you learn from your patients? Like looking back on your career as a physician, what did your patients teach you? And it's a tough question.
That's a very hard question. They taught me lots of things, and I can't think of one offhand. They taught me to control my temper, for one thing. Some of them were very demanding.
Yeah. In terms of cancer, my understanding was in years past, it was not discussed. You knew the patient had cancer, but the cancer was not spoken of.
Yes, that's another interesting issue. Years ago, I had patients with cancer, and I'd break the news to their children. And they would say to me, "You mustn't tell my mother, you mustn't tell my father. It would be devastating." And I would actually go along. At the beginning, I actually went along with that. And the first time, I said, "Nothing doing. Your father deserves to know what he's dealing with." I think there were 3 children in that family, one of whom argued for not to tell Daddy. The others of whom said it was okay. They were all patients of mine, and the one who didn't want me to tell Daddy became so angry he never spoke to me again. But that's a lot different now.
Do you think the patients knew? Even though you didn't tell them, they knew?
They must have.
Yeah.